So I'm Angela Liu from the Center for Care Innovations, and I want to welcome you to CCI's Raven e-learning series. We've developed the Raven e-learning series to highlight technology solutions that address priority areas that have been identified by the safety net provider community. This series is designed to be a learning opportunity as well as a Q&A session, and we'll encourage attendees to engage with our faculty during the session. And you can do that via chat, or if you have a really urgent question, you can always unmute yourself and ask it on the line. Today's session is focused on interoperability. We'll be discussing MOCI, an open source self-service interface engine, and our faculty today will show us how to use MOCI, how to use HL7, and how to establish and manage inbound and outbound connections. Our faculty today is Mark Olszewski, Chief Data Officer at Danica. Mark is deeply committed to supporting safety net organizations as we develop new and innovative ways to achieve better health outcomes for our patients, and is one of the folks behind the development of MOCI, along with Ray Pedden at CCI. Since March 2015, Mark has served as the Chief Data Officer at Danica, and before that, he led clinical implementation teams at Epic Systems. During his time at Epic, Mark specialized in cross-application workflows, clinical workflow optimization, and healthcare application security. He's since applied his skills to improving patient portal implementations at MedSeek, which is now Influence Health, and building tools for safety net communities at MOCI Health, where he was a Rock Health V4 alumnus. He's previously won awards for healthcare application design for Microsoft, Allscripts, UCSF, and Twilio, and is an active open source health data enthusiast and contributor. So I'd like to welcome Mark.
Hi, everyone. Thanks for the introduction, Angela. I totally forgot I had a bio in this, so my first few slides were talking a bit about me, but that was a pretty good introduction. Mostly just to set the stage where, part of this is going to be talking about the work that we've done with MOCI, helping organizations streamline and make it easy for a lot of different organizations to be able to share and collaborate on health data sharing, not only with their own organizations, but with other partners that they might want to work with. But talking a bit about some of the specifics of health data right now, especially in the United States, where for the first time, maybe in 30 years, we're doing something new and interesting with health data. So talking a bit about the current state of health data, and then some just recommendations for as you're thinking about health data or how you'd want to work with your partners, and especially some lessons that we've learned working with FQHCs and other organizations in the safety net, some ways to approach thinking about the problem. Yeah, that was just some more about my bio. But for me, as Angela mentioned, I've worked at Danica for about 4.5 years, where we've been trying to really make it a lot easier for people to understand health data integration. And some of that, discuss it, maybe talk about the history of our company, would, help you understand why, we care so much about this problem. So my boss is a guy named Dr. Travis Good, who is one of the founders of our company alongside Mohan Balachandran. Danica was founded in the year 2013. We were actually called Catalyze until about 2 years ago when we rebranded. But Travis, Mohan were, at the time, trying to build a professional network for medical students and residents. And they were trying to, really get their foot at the door in all of these organizations. And every time they went, they had two questions that organizations were always asking them. How are you going to handle HIPAA compliance for the application? Everyone had their own custom questionnaires and things they wanted to know, and they were working with vendors. And the second thing was, how are you going to integrate these solutions with our EMR? How are we going to make sure that work from the other system that you're building is going to get in there? And they quickly realized that maybe a social network for medical residents wasn't the right business, but that there was really a lot of opportunity where organizations could use help with these two problems. And over the last 5 years, our company has built out a product suite to help organizations to be more agile in the cloud computing era, where, especially since meaningful use digitized a lot of health data provided, organizations like yours with electronic medical records, really, a way for people to be able to take advantage of that, and especially be able to fill in some of the gaps that EMR vendors really aren't solving for their customers. Our company has about 150 customers, and we're trusted, from everybody from innovative startups to healthcare organizations like Methodist Le Bonheur, Stony Brook University Medical Center, to vendors like Microsoft, Healthgrades, life sciences organizations like Johnson & Johnson trust us to help them solve their problems. We have a pretty deep commitment to the safety net. Some of that comes from me, where the last company that I had worked with was focused wholly on delivering solutions within the safety net. But a lot of the time, that me and my team have worked, we've seen the need for organizations operating in the safety net, FQHCs, nonprofits, to really receive good technology or receive technology like academic medical centers or your large IDNs like a Kaiser are really getting. And it's interesting, we started this 5 years ago. A lot of people told me that was a really bad idea, that we should just focus on, as Epic would call them, your academic medical centers, your children's hospitals, your whales. And that really, didn't sit pretty with me. If we couldn't build a system where we couldn't help our customers deliver solutions everywhere, I wasn't really interested in being a part of it. And we've really had a lot of success with it since then. Some of these organizations may be your customers. I know some of them are CCI and CHCF innovation partners. But companies like CareMessage, Propeller, HealthFinch, Care Directives, and Welcome Health, we've helped them bring a lot of integrated solutions to the safety net. And a lot of them, you'll hear a lot of talk in the tech circles about the blockchain or artificial intelligence. Not all of the solutions we're delivering, are computer science or scientific marvels. A lot of things we're doing are helping with programming, delivering appointment reminders, making it easy for care coordination for, clinical end users, and the safety nets. And that's why, when we started working with Ray and the CCI team on helping organizations deliver integrated solutions, and when Ray asked me to give this talk today, I was really happy to do it, since a lot of companies and a lot of organizations have made it their business to make it seem like interoperability is really hard. Or it's really complicated, but it's really tenable. It's really something that your organizations can do, and it's something we've done in the safety net. We're going to, this year we have plans to help our customers connect to over 100 healthcare organizations in the safety net, in addition to the organizations we've already connected to. So it can be done, and we'll show you a bit about how that works. Again, some tips specifically for you, and get into that. So when we talk about health data integration, a lot of your discussion is around the health data standard called HL7. HL7 is an organization, and it's also the data transfer protocol for health data. If you've come from outside of healthcare or healthcare IT, you might be asking yourself, why do we use these data formats? And you might be asking if there are any kind of alternatives. I'm a big fan of history, and I always like to bring that into context whenever we discuss how we do things with health data in the industry today. So, as far as technology goes, 1972 was the year that the first EHR was invented and was used. There weren't really vendors working on electronic medical records then. Usually it was informaticists within a hospital trying to build their own digital system. The first EHR was built at Regenstrief down the road. I was going to say, it's a very Midwestern term, from where I live in Madison, in Indianapolis. And everyone kind of did their own things. People were building more systems. You had lab systems, you had billing systems, that started to take prevalence as, personal computers and computing became more approachable in the 1980s. But we had just like a ton of different data formats to do things, and it was just wholly non-sustainable. So a private public collaborative to build things, part of it based out of UCSF, worked on a new health data standard for being able to exchange data. And in 1991, after a trial period using V1 of the standard, HL7 V2 was released to the world. And it gained popularity very quickly, where a lot of organizations quickly adopted it and told their vendors, hey, we're not going to work with you unless we can support these data standards. And to see how far we've come, if you want to know about HL7's maturity as a data standard, 1991 was also the same year that Tim Berners-Lee invented this internet, or as he called it, the World Wide Web at CERN in Switzerland. This is what an HL7 V2 message looks like. And this is the part that's usually the most intimidating to people, because this is gobbledygook. This doesn't make a ton of sense. It's almost like staring into the matrix. You can pull out some pieces of it if you spend a lot of your time kind of looking at it. So this is what is known as the PID segment, or the PID, the patient identifier. And within the PID segment, you can tell information about the patient. So for example, this obviously is not PHI, this is all test data. The patient's name here, located in the fifth segment of the fifth field of the PID segment, this patient's name is Logan Haney. And we can see, if we go over to the seventh segment, that their birthday is July 25th, 1931. Why does this read so terrible? Well, in 1991, the internet wasn't quite as good as it is now. Data was at a scarcity, especially if you were sending it over wires. And so there was a lot of incentive to have a very streamlined data format, in order to exchange data. That makes sense. If you look through, pulled up an ad from an old catalog from around the same time, where you could see the state-of-the-art 386, 33 megahertz processor power, to 200 megabyte hard drive, which you probably have a thumb drive that's about 8 times that size. Computer costs $4,300, state-of-the-art. Around the same time in the 1990s. So health data, making sure that it was in a truncated and packageable format was all very important to organizations at the time. And so, if you took a look at the utilization of interfaces at organizations pre HL7 V2, interfaces were very expensive. An interface might cost you $80,000 to do, since it was all pretty much custom work. And you can see right around the time of the advent of HL7 V2 that the cost of clinical interfaces went down pretty significantly. And as internet broadband technologies became better and better, the number of interfaces deployed at the average healthcare organization really began to go up higher and higher. But yet still, in 2018, we still have a lot of the challenges we've had with health data integration that in other verticals, like integrating with Salesforce for a CRM system or ERP systems, is still a bit mystical to people. And so over the last 5 years, I've built out an interface team. And we've helped build products like MOCI to help, work within organizations like CCI to help people deploy interfaces. And we'll show you a demo here as soon as we're done with this. But I wanted to include some tips of how I think about data integration, since the technology is obviously very important, but thinking about it strategically is also important as well. And some rules that I try to apply when you're thinking about health data integration. So the first thing is that you need to work with your EHR vendors for initial interfaces. You can use an interface engine like the one that we provide with MOCI to distribute those interfaces to multiple systems, multiple vendors, multiple products. But you need to work with the EHR vendors first. And especially depending on who your vendor is, sometimes providing them interfaces, sometimes providing their customers interfaces is the thing that they are mostly interested about. Since a lot of them feel like, if they let some other partner or some other company have data, that the next thing they know, they're going to replace them entirely, which is mostly an unfounded fear. Pretty much all the customers we work with aren't trying to replace EMR vendors. They provide supplemental features like appointment reminders or population health analysis or care coordination, things EHR vendors don't really do. But the thing to make sure that you do here is that you just keep on them with these type of requests. You're probably familiar with your relationship with your vendor, but if you haven't had to buy an interface before, making sure that you're familiar with the items. And what we often do when we're doing this with our customers, working with people, is to be as specific as possible. If you can narrow it down to a SKU, usually it helps that process out a lot. One thing worth noting, especially if you're working with technology vendors or there's some problem that you think you can solve with an integrated type solution, is to make sure that you're doing a basic evaluation on the cost value of an interface, knowing what vendor cost and efforts are going to be. The first time you buy an interface from a vendor, it typically has about a one-time fee, between about $5,000 and then as a 20% maintenance fee on top of that. And for, a lot of organizations, that's a lot of money. Let's be pretty straightforward about it. And so, for your organization, you may be thinking, should I buy this, or can I just staff up personnel instead to solve some of the problems this interface would do? Since your interface, and your integrated solutions are pretty much replacing somebody taking data in one system and manually documenting it in another. Interfaces are what replace that. And, if you think about it, where, the cost of staff for like a medical assistant, depending on what your locale is, thinking of, is this work that if I would just give it to a person that they would do, that would be just as safe, there wouldn't be any impacts to patient safety and misdocumenting some information that I would have from the downstream system? Is it something that can be done at scale? The nice thing about automated appointment reminders is that if you have 10,000 appointments, you could have the best front desk the front office in the world, but they're not going to be able to call 10,000 people automatically and let them know if their appointments are coming up, or give them the ability to be able to reschedule them. So thinking about that, versus when you should have interfaces or not, because a lot of vendors, and I know a lot of them are customers, are going to prefer an integrated solution because they think it makes their solution stickier. But it may not always behoove you, or there might be a simpler solution involved. So making sure that an integrated solution works for you and works for the partners that you want to work with. The next thing, and you should encourage vendors to do this, but you'll want to make sure you do this as well with your vendors, is that making sure that everybody that you're working with has very specific asks of data. When I talk to, some of our vendor partners, when we're doing data integration work, I'll ask them like, so what data do you need in order to solve the problem and, ensure the value of your application? And they'll say, well, Mark, we need everything. And that doesn't work. It doesn't work for two reasons. One, that's not how health data integration works. Second is because if you're familiar with the rules in HIPAA, to some extent GDPR, if that's something that you've been thinking about or working on recently. But HIPAA specifically says that you should limit, based upon data that you share people with, including business associates, limit data that you send to other people, to other organizations. And that's your responsibility as a covered entity. And making sure that you only send the data as needed and necessary, and filter out any other data as needed to that organization. Basically providing the minimal amount of data you need to provide in order to help people with their jobs. The next thing to think about, and this is one of the trickier parts when you're starting with health data, but you pick up pretty quickly, is understanding how and when you need data. HL7 V2 is not a query-based system. You don't pull data out of the EMR using it. HL7 V2 operates on events. Sample event is an appointment is scheduled. That's an event. It triggers an HL7 message. An appointment is updated. That triggers an interface message. There's a new result that triggers an interface message. There's a new order. A transcription is written back into your system. Those are all examples of events. And that's how HL7 V2 works. There's a few exceptions to that, but they're pretty rare out in the wild. And then, so when somebody asks you, or you're trying to think if you need to implement an interface, the top example that I would think of, depending on if you already have the interface licensed or how hard it is to expose, is does the data that you send to these systems or to people need to be in real time? That mostly dictates whether you need an interface or not. If it doesn't necessarily need to be in real time, reporting or some other solution may work better for you. You may be able to work with your EMR vendors like that. The MOCI solution supports non-real-time data. It can consume flat files. It can do ETL. It has a bunch of other different capabilities, so don't feel like it's HL7 or bust when you're doing integration type work. But thinking about the data that you need during those events, again, knowing that you should reasonably be trying to limit data will take into factor, the interfaces that you should deploy and the work that you should do. The one thing, we didn't get the survey folks for people's backgrounds or the kind of work that you do, but I imagine some of you may be clinicians, some of you may be more on the operations side of things, some of you may be very technical. But the one thing that I always encourage folks to do is that workflow integration is just as important as technical integration when you're integrating a product, especially if you're looking to write data back into the EMR. Knowing where it's going to go and making sure that it's useful is just as important as actually building the interfaces themselves. I was reading an interview the other day. Somebody was asking a clinician about data from external systems, and they referred to the media tab of their EMR where they received these other reports were the place that patient information went to die. And I felt like it was true. I was like, oh yeah, like that's a place, if your minimum requirement was to make sure that you were writing patient data back into a system, mission accomplished. But otherwise, making sure that you understand the efficiencies you're going to get from the integration, where people are going to be able to see the data that's integrated, and make sure that you're actually getting the efficiencies that you're planning for when you're building those integrations. If you work in the health tech segment, you may have heard of a new data standard called FHIR. That's how FHIR is pronounced. That will supersede or replace HL7 V2. You may have heard a lot about it, some of it from your vendors. NextGen, eClinicalWorks, GE have all made announcements of it. Meaningful Use Stage 3 required vendors providing patient portals to be able to provide patient-facing APIs, which many vendors are doing using the FHIR program. And FHIR is going to be the future of data integration. It has broad support, not only from the EMR vendors, but from other vendors as a whole, including Microsoft, Salesforce, Google. A lot of different organizations are putting effort towards FHIR. But you still have to solve your health data problems that you have now. There's an organization based out of Boston, where it was originally funded, called SMART. And they have a great guide on which vendors do which amount of support for FHIR. So making sure that, if somebody comes to you and says, well, we don't support HL7 V2, we only support FHIR, well, your options may be limited in the amount of data integration you can do with them. So you're still limited to your traditional options like your HL7 V2 messages. If you do work with any HIEs today, your ability to exchange continuity of care documents and other CDA formatted documents instead of your traditional FHIR objects. And it's worth noting, if you're thinking about integration problems that you have, if you've already thought through some of this, the MOCI supports pretty much all major health data formats. It can do work with DICOM, X12, flat files, ETL, and can provide them in all meaningful ways for you. And again, I kind of realized that this is a lot of data. This is a really speed talk to give about data integration, in about 45 minutes. Where it can be really confusing. You don't feel like Tony Stark whenever you're at the helm of trying to figure out health data integration. But one of the things that we've tried to do in one of the intents of MOCI was to help you pick the right tool for the job. Since, if we're all being really honest with ourselves, there's a billion ways you can build a healthcare integration. You can code them up. There's a ton of interface engine vendors. There's a bunch of people trying to do this in new age kind of ways. As tech becomes more prevalent and all companies become tech companies, there's a lot more tech type people who can help you with things, who might have different recommendations. But part of the reason why we build MOCI with Mirth Connect, or as it's called now, Next Gen Connect, was basically two reasons. One is that it's open source. So that you have decent portability of your data across customers. And the second is that a lot of the interface engine vendors on the market exchange data, would charge people by channels or would charge people by things that didn't necessarily provide value. And the nice thing about MOCI is that we can build as many connections to your organizations as needed without necessarily incurring interface engine costs, which is really nice since you can take and basically do an experiment with an interface without incurring that cost on your interface engine as well. So with that, I'm going to show you a demo of how we build interfaces. And I'm going to give you an example of a tool that we built to help with care coordination using Microsoft Teams. And then we'll have some time for questions, or we can dig into anything else that we had from the presentation. Here we go. So this is Mirth Connect, and Mirth Connect has, we got a chat here. Okay, asking for questions, awesome. So this is Mirth Connect, and your primitive item that you have for building an interface is a channel. And so I'm going to create a new channel. And then you have three parts to that. And the most simple example is HL7 V2 to HL7 V2. So your EMR sends it and you're going to send it downstream to another vendor who wants that data. Depending on where you're sending it from, you might receive the data a few different ways, but your most common method is via this TCP listener. And this is how you elect to receive the data. You set a port, you set some other information, and the defaults here are pretty good. You don't have to worry about your advanced configurations much. We don't for most of the things we set up, other than making sure you're deploying a new port for each interface. But this is how you will receive the message from the EMR system. The next thing you have, you don't necessarily need to do this. Sometimes you'll just send the data right along downstream to the next system, is some amount of a transformer. So, for some customers or for some people, you may need to map data very specific that you can't do easily in your EMR system. This is where you really unlock the power of the interface engine. So you don't have to ask your EMR vendor every time, to change the value of some kind of a field, because you need to change things between systems. So here we have our inbound template. I was mentioning earlier, where we were talking about things where this is really hard to read. Here's a secret. I do this for a living, and I couldn't tell you what a lot of these fields mean. But what I can do is I can punch this into the message template field here in my Mirth Connect engine. And when I click on message trees, it tells me what these fields are. And it gives you a nice little view of what these are, where it's like, yes, PID 22 is patient ethnic group. Yes, PID 19 is the field that the social security number for the patient is. And it even has a nice search field. So if you say, I know that, your filler, item for the appointment ID is here, that's what I would need to look for. And this is a good companion to something like, the implementation guide that a vendor would provide for their system. For example, this is and this is on OpenEpic, so this isn't secret or any kind of information. But your vendor should be able to provide you with information about the interfaces as well, that between your Mirth Connect instance and some of the comments on implementation from the vendor itself, you should be able to determine most of what you need to be able to do an integration with. For example, you could see here in the Epic Guide, they have some information about what some of the fields would mean and where they're using some of the items. So for example, PID3 has patient identification information. Epic has some specific notes on how some of these things are done. But going back to that, again, if you needed to do any kind of mapping, you would be able to, pull an item here. Say we wanted to pull something in like patient name. And we would be able to change our mapping to some other item as we're pushing it in through our system. And you can do this in a way that's very simple, or even if you need to do something that involves a bit more work, there is JavaScript mapping, and we'll show you an example of how that works in the next step. We're going to get rid of this so that it doesn't mess up our validation. Then the next item then is to send this to a downstream system. And a lot of HL7 is transmitted over VPN, but it's not really a requirement. You really just need to encrypt the data and make sure you have some kind of authentication. And a much cheaper way to do this, if you didn't have requirements around VPNs, would be to send it over HTTPS, like you integrate with most average healthcare or most applications on the internet today, where we would be able to send data to something like, we can validate our connection. Oops, we need to specify that it was HTTPS. That's right. There we go. And be able to send that message here. And that's how you build an interface. Again, it's really not that complicated at the most base level of what you're trying to do. There are some nuances to it, but really, it takes me about a month to train someone to do interface engineering if they're familiar with some items or some of the specifics of clinical workflow and other things you need to know in order to do this. So it's really approachable. It's really something that can be done. So what's a good example of an interface? What's a good example of an integrated solution that you would build or something that you would want to do? And my example that I'm going to show of this is around care team coordination. We've been working with Microsoft as a company on how to better integrate Microsoft Office into healthcare organizations, building tools for frontline caregivers, to meet gaps in care coordination. The interesting thing here about Teams is that it's something you might already have. You might already be buying licenses of Office 365 for some of your customers today. But what I'm going to do is I'm going to trigger, if you had a group of nurses, providers, cross-disciplinary group who is responsible for taking care of a specific cohort of patients, what I can do, and I have a developer tool here that's going to simulate sending an HL7 message. So this is an HL7 SIU message. So this is the kind of message that's sent when an appointment is scheduled. And this is S12, which indicates that this is a new appointment. So what I'm going to do is I'm going to send this message, and it's going to go into MOCI, and it's going to generate an event, which we're going to be able to show a care team in Microsoft Teams. So I'm going to send this. It's going to take a second. It's going to tell me it's okay. And it's going to tell me that I just got a new message. And it tells me that an appointment was just scheduled for the patient we were tracking. And we have the ability to take some actions here. So of course, not a real patient, but we can see our patient name, medical record number, the patient location. If we had any information from it, like who the patient was assigned to from the message, due date, and any other information that we would need in order to do something as this care team to be able to discuss this patient. We've given them some other options here. And we can see some of the data that we sent in here in this HL7 message. So the patient's name was Jack Williams. Here was Jack Williams. This was the location of the visit, at Access Community Health Family Medicine. That's how that was placed into here. And we do this today. We have live integrations that look like that, but this is actually really simple to build. Let me show you this Mirth channel. I feel kind of like I'm on a cooking show whenever I do some of these examples, where it's that, here was how you would build an interface from scratch. But this is how we built this. So we exposed the port to receive this message here on port 4444. We built an object to receive this. So the implementation that you do this with Microsoft Teams is you build something called a card. But most of what you're doing is you're doing your data mapping. So you could see that we pulled that patient name by pulling in these segments of the PID here. We pulled in the patient's medical record number. We pulled in the patient location. We pulled in the patient phone number. These actions, which we have done some work on in the past, was work that we've done integrating this with all scripts. You don't necessarily need buttons. You can just have the notifications themselves. And that's how we populated the data in the system. And then when we're done, we send the data downstream to Microsoft Teams. So here is the URL of the webhook of how this is sent downstream in Teams. We send it to this, and it knows that it should receive the data in this format. I have Teams on my desktop. I didn't mean to go to that one. Yeah, we can see that it created this object here in real time in our downstream system. So, and this is the kind of integration that we do with Care Message. It's just that whenever we receive notification of a new appointment or an updated appointment, we schedule an appointment reminder. We do something similar whenever we receive notifications of a refill for HealthFinch. It's not an appointment item, but it's information about a refill. We did orders for enrollment for new inhalers with Propeller. A lot of your use cases, again, people think that it's really complicated, but most of these applications, a lot of these really innovative things really need simple data signal to become a lot more effective. And they weren't that hard to build. So you could see where it is, how it works in action here. But you've got a lot of potential of what you can do without having to do a lot of lift from your end, especially if you can take existing interfaces that you already have licensed from your from your EHR vendor, using something like MOCI to be able to extend those to other vendors who might find it be useful. All right, so that's what I had for presentation. I want to make sure that I put a cap on this here before we take questions, but we want to make sure that we help you with any questions that you have. I'm sure you know how to get in touch with the folks from CCI. But if you have any other questions, I want to make sure that we're helping you with any questions you may have about health data integration. I try and help people with questions a lot, from Quora to there's a pretty good healthcare technology community on Reddit, to random people sending emails, to even the chat box on our site. We have some business things going on, but really it's just a passion of mine to try and demystify a lot of things with health data integration. So if you got any questions, if you think of something after the presentation, or you wanted to know something more about Mirth Connect, or anything that we do at Danica, this is my email address. The hello one is the general email address for our company. Let me know. I definitely would love to talk with you more and be able to help you out. And with that, I'll reserve the rest of the time for questions or digging in anything deeper that we might have.
Great, thank you, Mark. And it doesn't look like we've gotten any questions to the wider chat, but I don't know if maybe people have sent it directly to you. Otherwise, please feel free to hit *6 on your phone to unmute yourself and ask a question.
Oof. All right. Either everyone is just stunned by how awesome that just was, or everyone's in the middle of a Friday nap. So, I mean, I can keep going. We can discuss other topics. We can discuss other use cases. I mean, maybe a question, I can ask folks, if anyone wants to talk. I mean, what are your existing experiences with data integration? What are your challenges? Let's chat.
So I wanted to bring something up. We actually worked with a client recently who had ShareForce access. I don't know if I'm going to explain this right. So if I'm not getting the data terms right, I'm really sorry. But they had an instance of ShareForce, so they had a license, and they had a client who had data that they pulled to that ShareForce license, I guess. And the client wanted access to be able to view their own particular data through the ShareForce, whatever, the database, I guess you could call it. But it was this whole complicated runaround. And at that time, I didn't really understand it. And I don't know if you're able to shed a little bit more light on it since you mentioned it. Why is it that separating firewalls when it comes to giving people access to like HIPAA compliant data is such a complicated thing?
Sure. So I don't know any of the specifics around ShareForce. And, the one thing I often tell people, I mean, HIPAA compliance is 50% of our business. Obviously, it's our job to know a lot about it. And we've done a lot of work trying to, similar to data integration, demystify it in the space. But the thing about HIPAA is it's almost like the dog ate my homework. Same thing with interfaces. Where people will use it as an excuse for everything, even if it's a really bad excuse. Where, folks will say like, oh, well, we can't share it with you because we're not sure if we can share it in HIPAA compliant fashion. It can realistically only mean three things. One, they can't share it with you in an encrypted fashion. Two, they're not sure how to cut the data down to a reasonable payload. In order to, pull out pieces of that data so that they only share the pertinent pieces with you. Like a good example of this, like we do data integration work for a medical device company. And it's very hard to know, okay, of these 150 knee replacement surgeries, these are the ones that use your knees, right? But as for, that, like those are some common reasons. They're often really bad ones. I mean, I think a lot of things with data integration, especially if the company doesn't really have a way to turn it into a business, which a lot of people don't, this is sad, like it's really terrible. A lot of people just say no to data integration and will try and make it really hard. I don't want to use the term data blocking, but let's use the term data slowing. But making sure that you're pushing on people, in order to be able to provide those solutions. I mean, we provide project managers on pretty much all projects we do because of the amount of, as we would say in Wisconsin, badgering that needs to be done in order to get people to do things or to do things like sharing data, since a lot of people's default stance on data sharing is no. Making sure that you try and get people to, at least switch that to maybe or yes.
That makes sense. And I think that was one of the hardest things that I think I personally faced when working with that client, because I didn't know where the lines were of what someone is capable to do in terms of data sharing and what are, like you were talking about, excuses or data blocking or whatever it may be. And I think like because I don't come from too big of a data technical background, any like words that come up about, well, like this can't be that way, and then it's this whole HIPAA compliant lawsuit, it just makes you scared and then you kind of back off. So I just was curious, just based on that experience, what like the HIPAA compliant is like. So thank you for talking about it.
Yeah, no, of course. And it's, okay, go ahead. Is that you, Angela?
Oh, sorry. No, this is just Angela. I'm wondering if you can share, Nita, your name and organization.
Oh, sorry. Yeah, my name is Nita, and I work for Wise Healthcare.
Thank you.
Hi. Do we have time for more questions?
Yeah.
Yes.
This is Bill Tan. I'm with Transcendent Endeavors. We are a developer of digital health technologies. We're working on a project to assist a group of FQHCs on reducing appointment no-shows for the adolescent population. So the way we're approaching the situation is to help the clinics engage with the teens and the family members, provide them with incentives to make it easier for them to show up. And we want to keep track of what the upcoming appointment, what the individual patient's upcoming appointments are, and whether or not they had actually shown up or they missed it or they were late. And we're also looking to see if better appointment attendance would have an impact on their Medicaid or the prospective PPS payment system reimbursement. So could you walk us through a scenario, if it's possible, how we can leverage MOCI to achieve those data exchange and integration needs?
Sure. So there's two ways to get signal from appointment. To meet your use case, you need to know, you need to know the complete circle, right? You need to know whether or not somebody actually showed up. As you described it kind of in your problem set. So that's where an interface for appointments is really effective because you receive not only the initial appointments, you can send reminders, you can try and provide people with as much notification as possible around no-shows. But one of the things that you get in that signal for the scheduling feed is updates on when the appointment, the patient checked in or not. Let me share something to you here. I can show you kind of the specific field you have. So here in these HL7 messages, what you have is, so you have this field, and here you have what's known as the filler status code, here in SCH25. So your original filler status, it's kind of a clunky term for it, but basically it's the status of the appointment. So like you have new appointments, you have whatever it is. So this field, you would receive a message when a patient was checked in, and you would receive a message whenever the patient left the appointment. So if you didn't get a check-in from the patient on the day of the appointment, and again, this is where a lot of our other customers, including an organization like CareMessage, is trying to make sure that they're getting the reminders out to people and provide some signal of what their no-show rate's going to look like. But you can you could use this to determine when, patients have checked in, when they're leaving, where we've even worked with other customers on that, where people have used the signal like this to replace press Gainey type surveys where they're text messaging somebody a survey the second that they've checked out of the appointment at the office, which is pretty cool. Of course, you need to explicitly check them out in the EMR system, so you make sure your workflow works. But this data feed would provide you pretty much everything you would need to be able to solve that kind of solution with a healthcare organization, which we're using this data feed a lot with vendors for appointment reminders, so it's definitely pretty approachable from a development standpoint.
Hey, my name is Armin. I'm a software developer here working at Transcendent Endeavor with Bill. I'm seeing that object on the generated script. Yeah, the one that like your pointer is right at. Is this, can you just like quickly walk, because I can see a name for the patient and an HL7 message as the value. Is that the format type that we are going to receive from MOCI, or we are going to send back to MOCI? Can you just like give me a little bit details on that?
Yeah, sure, definitely. So again, going back to, so you have the input, you have the transformer, you have the output. And you can see, not only, I can't believe I skipped this, your interface engine also has a history of everything that was received and sent. So this is what was received, and you can see the timestamp of it here, since obviously it's important to track interface messages to make sure they succeeded. When they fail, my team usually gets a message so we can help fix it. So this is the message that we received for Jack. Here we can see that we had the mapping of how we transformed it. So this was the item that we generated, this JSON object. And then we sent it downstream to this URL, and I can see here, you could see the message that was created, so it was successful, but you can see that, it flagged an okay response there. Again, if you were just sending HL7 to HL7, you'd still be able to view the data as you had it mapped to see what was being sent downstream and what was any changes to it. So if there were any problems, you'd be able to debug them using the tool.
Gotcha, thanks.
Anoop Kendall asked the question, is there a documentation detailing best practices on how to best use MOCI with MRS Connect to build interfaces? Yes. Ray Pedin, who's not here today, wrote up a bunch of documentation based upon documentation that we had written. We've got a lot of really great tips. One other thing that I can share with you is we've open sourced a lot of how we do interfaces at Danica, like pragmatic ways to transform data. Open sourced, entirely free. It kind of gives you a good place to get started with Mirth. We've also included a lot of other stuff, like libraries to make managing dates easier to manage. You can check those out and you can download those online. I'll include a link to this. I'm not sure what the GitHub link is off the top of my head, but I'll include it in this chat here and make sure that we get it included in the notes.
Yeah, and I can send those out to as a follow-up.
Awesome.
Yeah, I'm wondering, I see a few of our Technology Hub participants on the line. Derek from Neighborhood, Story from Santa Cruz, Marina from Neighborhood, and Steven from Northeast Valley. Do you guys have any, I know you guys are always working on projects, and interoperability is always the first priority. So do you guys have any questions to ask of Mark?
Hi, this is Story. Not really. I mean, part of the problem is I don't have a software engineer on staff that could help really flesh this out per se. And so right now I'm relying on third-party vendors to help me solve some of these issues connecting HL7 interfaces to text messaging platform or kiosks in order to exchange data. But it's interesting.
And we provide some of those services too. I mean, MOCI, definitely isn't just, here's an interface engine, you're on your own. I mean, part of the intent was that we were able to provide services, with CCI to be able to help, people with those type of things. I mean, the thing that I would, kind of note is that, people think that they necessarily need a software developer to build interfaces. You probably don't. I mean, if you want to know the profile, a lot of people that I hire, a lot of them didn't necessarily have technical type backgrounds, before they started on my team. Mostly, trying to hire for, people who are trying really hard, people who are really driven. I try and hire people who are familiar with the workflow-based type things of, clinical workflows, since so much of data integration has to do with that, understanding what the people behind the scenes are doing that matches up with the data versus vice versa. And a lot of the things, within Mirth, again, I say this, I realize I'm a programmer, but it's really, really basic programming. And the nice thing about it, the care that you can provide, somebody who would want to learn this, if you want to give them opportunities to be able to do it, is that interface engineering is a great job. There's a ton of careers in it. Not that you'd want to see your own team members leave, but being able to take an opportunity and work on some of it, especially with backup from CCI and MOCI, to be able to help people out, is something that we could help you develop your team members alongside of it, so they could learn how these interfaces would work, and be able to develop those kind of skills internally. Again, I know that's, you've probably got 100 different priorities, so saying like, getting somebody trained up on that is good, but, you don't necessarily need to pull in somebody who's already really, again, like I much prefer people who know what it's like in the clinics, what it's like actually doing things in the EMR versus having somebody who's really an ace programmer. I feel like you get a lot better results out of the former camp than you do out of the latter.
And Mark, you had mentioned some like open source resources for kind of learning some of those skills. Is that something you can, I didn't catch all of them, but are there certain links you can send me after, and I'll also include that?
I know Ray had a specific version of it for MOCI, but we have documentation on it on our website, which I'll send along, and I'll put something in the link here.
Great, thank you. All right, final call for one last question. Okay, I guess there are no takers. So thank you, Mark, so much for your time and sharing your expertise. That was a great overview of those three interfaces. And we hope to see you on the next e-learning series, which will be around texting. And that is, I believe, in February, February 15th. So you can look out for emails from CCI, and that will be in my follow-up as well. Okay, thank you everyone, and have a great rest of your Friday. Bye-bye.
Thanks everyone.